Good morning. I'm Dr. Tyagarajan Pandian, 4th Unit Chief, Professor of Orthopedics, Balaji Medical College and Research Institute. I'm going to talk about acetabular fracture. So in that I'm going to deal about mechanism of injury and management and treatment protocol. Acetabular fractures, anatomy, mechanism of injury, clinical evaluation, radiographic evaluation, classification and management. Anatomy, anterior column, posterior column, acetabular dome. Anterior column, the iliopubic component. This extends from the iliac crest to the symphysis pubis and includes the anterior wall of acetabulum. Posterior column, ilioischial component. This extends from the superior gluteal notch to the ischial tuberosity and includes posterior wall of the acetabulum. Acetabular dome is the superior weight-bearing portion of the acetabulum at the junction of anterior and posterior column, including the contributions from each other, both anterior column and the posterior column. Corona martis is one important artery. So the ascending branch of medial circumflex and superior gluteal neurovascular bundle. They exactly go along the acetabular dome. This is a acetabular picture from a lateral view. You could appreciate the iliac crest, iliac wing, anterosuperior iliac spine, anteroinferior iliac spine, and your iliopectineal eminence, and your superior pubic rami, and you can see the obturator foramen, ischial tuberosity, and the acetabulum. You can see both the anterior wall and the posterior wall. So, and your transverse acetabular ligament will lie in the acetabular notch. So this lateral view, then these lines is being told by Judet and Ratonal classification. The lines referred as lateral facing and not anatomical oriented acetabulum. So here the second image, which is showing you the yellow, purple and green and red. So the yellow line, the yellow color exactly falls on the anterior column, whereas your purple tells your posterior column, and your green is your anterior wall and red is your posterior wall. Mechanism of injury in acetabular fractures. It's mainly caused by high energy trauma secondary to motor vehicle, motor accident or fall from height. Direct impact to the greater trochanter with the hip in neutral position can cause transverse type of acetabular fracture. With indirect trauma, like in a car when they are traveling, so when the knee hits against the dashboard, so then the posterior wall is being fractured. Acetabular fractures can be associated, usually associated with hip dislocation or else femoral head fractures also. Clinical evaluation. First, we have to see about this ABC, airway, breathing, circulation, and we have to see about disability. And then, of course, the patient age, degree of trauma, presence of associated injuries like dislocation and other fractures. Neurovascular status is very much important, as there is a posterior venous plexus lies in the close to the iliac, lies close to the sacroiliac joint. So we can have your pelvic fractures, pelvic associated pelvic fracture can cause some neurovascular problems. And as I told you, the corona mortis artery, which lies close by, and soft tissue injuries. So the radiographic evaluation, we usually take an anteroposterior view, and we take an iliac and obturator view, that is called as a Judith views. So first your anteroposterior view. So in that we will be seeing your ilioischial line, that is the line drawn from the greater sciatic notch down to the iliac ischial tuberosity. So that is your ilioischial line. So second line which is drawn from the greater sciatic notch to that of your pubic tubercle, that is your iliopectineal line. So iliopectineal line tells your anterior column. Ilioischial line, which tells your posterior column. So, and we have to see the contour of head, and we have to see your acetabular inclination also in your anteroposterior view. We will be next view is your iliac oblique view. For to take an iliac oblique view, the view is taken by rotating the patient into 45 degrees of external rotation by elevating the unaffected side by keeping a wedge. So anatomic landmarks of your left hemipelvis. So the iliac oblique view best demonstrates the posterior column and outlined by your ilioischial line. Obturator view, it is taken by elevating the affected hip to 45 degrees to an horizontal beam by means of a wedge and directing the beam through the hip joint with a 15 degrees upward tilt towards the cephalic end. So the diagram of anatomy of pelvis on an obturator view, that tells your iliopectineal line. So that tells your anterior column. We can take a CT scan of your pelvis with 3D reconstruction that gives a clear picture for us. So in this image you can see your anterior column and a posterior column and your femoral head. Classification, that is your Judith and Latournal classification. We have an elementary fractures and associated fracture. Elementary fractures can be posterior wall fracture, anterior wall fracture, posterior column fracture, anterior column fracture, and transverse fracture. Associated fractures can be T-shape, posterior wall and posterior column along with anterior wall, posterior wall and transverse along with posterior column, posterior hemitransverse and anterior column in along with your other fractures, transverse fractures with the two columns. So this is an elementary classification. So anterior wall, anterior column, so transverse fracture, posterior wall, posterior column. So here in this both the columns there is a fracture. Posterior column with posterior wall fracture, anterior column with the posterior hemitransverse fracture. So transverse with the posterior wall fracture, and it's a T-shaped fracture. Management, initial management, patient usually placed in a skeletal traction to minimize further soft tissue damage and allow associated injuries to be addressed, maintain the length of the limb, maintain the femoral head reduction within the acetabulum. So if there is a central dislocation or a dislocation of a hip, we have to reduce it and then we can put them on a traction, either a foam skin traction or a skeletal traction. So usually we prefer putting a skeletal traction, that is call it as an upper tibial pen traction, which is used to keep the limb in traction. So management either can be a non-operative or an operative management. Non-operative management so may be appropriate in high-risk patients, elderly, presence of DVT, morbid obesity, open contaminated wound, late presentation more than 3 weeks, non-displaced fracture where there is no hip instability or a dislocation, Distal anterocolumn, superior pubic root fractures or transverse infratectal fractures in which femoral yet congruity is maintained. Maintenance of medial, anterior, and the posterior roof arches. Non-operative managements. So skeletal traction is not required in those cases since the we consider non-operative when the hip is in the within the acetabular dome. So activity as tolerated with crutches, weight bearing, the lowest joint reactive forces seen with toe touch weight bearing and passive hip abduction. So we usually give rest for at least 1 month. Then we allow the patient to put them on a partial weight bearing or a toe touch weight bearing walking and DVT prophylaxis and radiograph follow up after 1 month. Operative management done in displaced fractures, inability to maintain the congruity joint out of traction. So congruity of the joint out of traction, large postural wall fragment, documented posterior instability under stress examination, removal of an interposed intra-articular loose fragment, fracture fragment which can get into the joint space, does not include a fragment within the fovea that is likely tethered to the foveal ligament, a fracture dislocation which is irreducible by closed methods. Operative management. The surgery should be performed within 2 weeks of injury. Surgical emergencies like open acetabular fractures, new onset sciatic nerve palsy after close reduction of hip dislocation, irreducible hip dislocation, medial dislocation of femoral head against cancellous bone surface of intact ilium that is called as the protrusio. So, this is a skin degloving injury, otherwise called as moral lavalier lesion. This is an infected in 1/3 of cases with this lesion. This requires thorough debridement before definitive fracture fixation. Otherwise, we have to wait till the moral lavalier lesion gets healed, the soft tissues get healed, then plan for a surgical management. Surgical treatment, either it can be an open reduction and internal fixation with the plating or with cancellous screw. Otherwise, we can go for a hip arthroplasty using a cage fixation. Treatment algorithm for an acetabular fracture, non-displaced postural wall, stress examination under anesthesia, non-operative or operative approach. So, non-displaced fracture, other types, observe, remain stable, non-operative. Displacement evidence, consider percutaneous fixation. Displaced fracture, surgical fixation based on the type of the fracture. Surgical approaches, there are various approaches for acetabular fracture. So that is your anterior approach, your Coaches and Langenbach approach, so that is a posterior approach, modified Stopa, extended iliofemoral, extensile approach, combined approaches. So for fixing the anterior column, we have to go for the anterior approach, that is your ilioinguinal. And for fixing the posterior column, we usually prefer Coaches and Langenbach or posterior approaches. So combined approaches been rarely done. So we can do a modified Stopas when we are planning for both the fixation at the same time. X-rays of ORIF with plating showing this is an X-ray pelvis. Anteroposterior view, you can see a plate along your iliopectineal line and one more plate along your ilioischial line. So that they have then fixed both the anterior column and your posterior column as well. So this is one more X-ray which has been showing you a total lip arthroplasty. So if the acetabular columns are stable, so and if your acetabulum is intact, and then in that case we can resurface the acetabulum, and we can do a total lip arthroplasty. So complications following acetabular fracture fixation. So post-traumatic degenerative joint disease, that is the most common. After fixation, the patient can go in for a secondary arthritis. And later on, if the patient has had a secondary arthritis, we have to plan for a total lip arthroplasty. Heterotopic ossification, which can be avoided by using a good pulse lavage and thorough wash after the surgery. Osteonecrosis, while the patient is having a hip dislocation and the dislocation is being reduced, and for a femoral head fractures, that has to be addressed and that has to be fixed so that it doesn't go for a osteonecrosis. And deep vein thrombosis, immobilization can cause DVT and can be prevented by heparin injection. Pulmonary embolism, so can again we can use a DVT stockings, and we can advise limb mobilization. Infection, bleeding, neurovascular injury, and abductor muscle weakness. Prognosis, poor outcomes are associated with multi-system trauma, increasing age, poor articular congruity if there is a severely comminuted fracture, associated femoral head articular injury, post-traumatic arthritis. Yes, I have discussed about acetabular fractures. We have been seeing the mechanism of injury and anatomy of acetabulum first, and classification, simple and complex classification, and the treatment modalities, and the importance of acetabular fracture, particularly in a road traffic accident. We should not miss acetabular fracture. When a patient comes with an acetabular fracture, hemodynamic stability is very much important, and how the acetabular fractures has been fixed and the complications, we have to look into it, both the immediate and later complications. Thank you.